Just one second. Okay, so this is our week 7 presentation for genital pelvic pain and penetration disorder, GPPD. So in our group, we have Katerina, Kazia, Travis, and me, Jenny. Um, the etiology of this disorder is best defined as significant pain or difficulty with vaginal penetration and intercourse that has lasted for at least 6 months. Um, this disorder consists of 4 symptom dimensions that includes difficulty having intercourse, genital pelvic pain, fear of pain or vaginal penetration, and tensions in the pelvic floor muscles. This sexual disorder causes a lot of distress or impairment for women during initial penetration attempts, as well as fear and anxiety that builds up over time as they anticipate the pain. The general causes of this disorder are unclear. However, there are some indications that vaginal infections reported by women are often a risk factor, especially if the pain persists well after the infection has passed. Women who also have refused to wear tampons before any pelvic penetration can also be an early indicator of this disorder. Um, Environmental cause is that women with GPPD are more likely to report history of sexual or physical abuse, but it doesn't happen for that is not necessarily the case for everybody working through this disorder. Also, women with mood and anxiety disorders are 4 times more likely to develop this disorder.
Okay, so for systemic assessment of GPPD, you would use a couple of different tools. Pain mapping is one of them. There are also an assessment called a multidimensional vaginal penetration disorder questionnaire, the MVPDQ. Another one called the vaginal penetration cognition questionnaire, VPCQ, and the female sexual function index, FSFI. And with this disorder, it's very important to also assess the medical history. And this can include, not limited to, but including a medical evaluation. You can look at medications and symptoms and sexual psychiatric histories. Um, and then as far as the diagnosis of GPPD, the criteria would be that it's persistent or recurrent difficulties with one or more of the following. So it's vaginal penetration during intercourse, marked vulvovaginal or pelvic pain during vaginal intercourse or penetration attempts, marked fear or anxiety in anticipation during or results from vaginal penetration, um, or marked tensing or tightening of the pelvic floor muscles during attempted or as a result of vaginal penetrations. And the symptoms must have happened for at least 6 months, and they must cause significant distress or impairment. And also, we want to make sure that it's not better explained by a non-sexual mental disorder or as a result from relational distress. And some of the differential diagnosis that we will look at will be another medical condition. It could be pelvic inflammatory disease and genitourinary syndrome that resulted from menopause. Another differential diagnosis would be somatic symptom and related disorders. And finally, you look at inadequate sexual stimuli, which also takes a look at the client's partner. For example, the partner may have erectile dysfunction disorder, and this could contribute to the symptoms.
Some biological considerations for GPPPD. There are some underlying health conditions that might put women at risk for developing this disease, and that can include infections such as genital herpes and or candidiasis. Also, there's dermatological diseases such as tissue lesions that can cause a lot of irritation and pelvic pain. And as a result, both of these can contribute to that discomfort, which sometimes can develop later on into this disorder. There's also a lot of hormonal influences, such as menopause, that can lead to vulvovaginal atrophy, which is when the vaginal dryness begins, the vagina wall becomes very thin, and there's a lot of inflammation, which causes a lot of discomfort. And that can also be something that later on can develop into this disorder. And there's also muscular influences as well. There's a certain muscle tone of the pelvic floor that triggers lubrication, genital arousal. And so if these pelvic floor muscles are low or they're not actively worked, it could also put women more at risk to develop GPPPD. For treatment, therapeutic, and medical prognosis, the assessment and education is an integral part when initiated therapy. The sexual function of both the client and her partner should be assessed, and it is important to cover the frequency of the intercourse, other sexual activities, desire, arousal, orgasm, and satisfaction, and any other comorbid sexual dysfunctions. The treatment of GPPPD also targets four primary co-current domains of pain: sex, individual factors, and couple dynamics. The techniques in the first stage of therapy include reinforcing help seeking, validating the experience of pain, demystifying pain and anxiety, genital self-exploration, giving the woman control over penetration, de-emphasizing intercourse, and emphasizing affection and sensuality.
In addition, the treatment therapeutically and for medical prognosis for individuals with GPPPD, it would be important to address the pain and physiological processes. That would be coordinating with physical therapists, gynecological consult, and addressing any influences on pain. For individual processes, we would work on cognitive reframing, challenging sexual and relationship schema, and coping reconstruction. From a relationship dynamic, we would work in a therapy setting to help the individuals couple to bridge sexual and relational schemas that better fit, enhance communication. We would want to work from mind reading to asking your partner, from expecting mind reading to requesting what you need, and from lying to tactful truth telling. In addition, we would want to work on managing reactions from partner and their connection to pain, reestablishing a sexual connection, as well as intimacy, and addressing the function of pain within the relationship. Again, with sexual interactions in a therapy setting, we would work to build desire and arousal, making quality time, enhance self-perceptions of desirability. The use of erotica, books, and video can be incorporated, directed solitary masturbation, heightening awareness of arousal, mindfulness techniques and training, expanding sexual repertoire, corrective feedback, communicating preferences, body shifts, hand guiding, and introducing some levity into sex. As far as current research, research has come a long way in the last 20 years. A lot of our data suggests that um, heterosexual or gay men experience painful intercourse ranging from up to 5 to 15%. It's also important to look at individuals with chronic illnesses and or disabilities as another group whose treatments may result in painful sex and require more research and areas of clinical attention. Um, and there's an emphasis and treatment of this condition was originally on the properties of pain and somatic characteristics, whereas in more current research, GPPD is now recognized primarily as a pain disorder that interferes with sex. Any disorder that involves human sexuality is likely to be significantly influenced by both intrapsychic, interpersonal factors, as well as societal and cultural factors. And the shift in most of the current research has been for validating all groups that are experiencing pain. GPPD occurs as a result of interpersonal interaction, which is complicated, again, by either gendered or socially, culturally activities, politics, or ideologies within relationship, stemming all the way back to family of origin.
So with that last bullet point, we wanted to draw attention to the different diversity and multicultural dimensions that should be considered when working with this with clients or couples who are working through this disorder. And these are just some of the things that we thought should be considered. Religious orthodoxy, what are our clients' beliefs, spiritual beliefs or religious beliefs, and how strictly do they adhere to them. That's important to consider when with this disease. Also, first generation immigrants to the US or Western Europe, socio-political and socio-culturally cultural definitions of worth, stigma related to sex, sexuality, minority groups, individuals with chronic or terminal illness. We want to think about the intersectionality of all of these things, or also including other areas of sexual dysfunction or issues involving sexual health or physiological health. Other unspecified or specified mental health issues, disabilities, and views of individuality and individually or collectively the perceptions of sex, sexuality, sexual expectation, roles, performance, the performative nature of these things, gender, and feelings related to sex and intimacy. We're also wanting to consider intergenerational factors, trauma, histories of trauma, whether experienced or observed. These might also play into our client's experience with GPPD. So our presentation this afternoon is concluding with a list of references. We just wanted to, make sure that we highlight these and extend our appreciation for these resources and references as they helped us put together this presentation today. Thank you so much.